Hi, Jeremy Cordeaux in the Court of Public Opinion. I'm just on air here to let you know that we'll be live streaming the Court of Public Opinion every Friday between 9 o'clock and 12 on jeremycordeaux.com. Please join us. We'd love to have you.
Dr. Travis Brown, what is This Medical Life all about?
This is the pursuit of knowledge as we learn about diseases from the ancient times to the present day. These are the stories of medicine.
Dr. Travis Brown, last time you touched on the prostate. I squirmed in my seat all through the recording. This time it's PSA, Prostate Specific Antigen.
Yep.
How should I brace myself?
Well, this is probably a confusing time then for yourself, actually. And the reason why I say that is because PSA, prostate cancer and screening is a really murky issue. We've just finished a series on breast cancer, and that's probably the perfect example of a good screening test that is accurate, that is sensitive, specific, everything you want screening tests to be, that would be it.
Yep.
If you had the other side of the coin when you wanted everything to be murky, not clear, not quite a good test, you would turn to prostate cancer and PSA.
Yep, I'm squirming already.
And this is the hard thing. Look, PSA, so this is, yes, as we say, prostate specific antigen. So we just abbreviate to PSA. Now, this is actually, it's a normal enzyme. It's normally found in semen. Mm-hmm. And what the definition is it liquefies seminal coagulum. Now, what does that mean? It means that semen will normally coagulate without this enzyme in it. So, and that's not good for reproductive purposes. So you actually need this protein, this enzyme to dissolve that so that
it flows.
That's right. And able to procreate.
Yes.
So there you go. Able to get to the egg and fertilize the egg. Now, we find this a lot. It's the concentration's highest clearly in semen, but it's a millionth lower in blood. And that's where we go to test it. Now, looking at prostate cancer, I wanted to go back and look where we've come from. And we wanted to look back 200 years ago to when we were examining this prostate cancer and starting to get our understanding of this. And it does take us back to the 1800s. And the person I wanted to just touch base with, his name is John Longstaff. And he was a surgeon in the early 1800s.
Sorry, did you say John Longstaff? Okay.
I better check that. It's George Langstaff.
Oh, okay.
So a mispronunciation on my behalf there. Now, he was a surgeon from the 1800s. Now, he was clearly educational focused. He was a teacher at heart. He even established a museum. He published a catalogue raisonné of 10 volumes that included 2,380 specimens. In all of his studies, he did a paper, and he published, it was 6 cases in 1817, on a tumour that he called fungus hematoids. And the tumour was what they described was a fungus-like growth. It could be internal or external. So clearly they're talking about tumour and they're talking about cancerous tumours. But they're trying to classify them. And he's looked at it and he said, this is a tumour that causes significant bleeding when cut. And so he put these 6 cases. One was external, which was a 45-year-old man who had a marbled-sized mass on his right tibia. And they resected it, and it recurred, and then ended up having to amputate, but he ended up, the cancer grew further and further, and he ended up dying from this growth. We have these other patients. There was a 52-year-old who had an ovarian or a uterine mass, 2 kidney masses, and liver masses. And what he's done is he's pretty much said, well, these tumours all look the same. They behave the same when I cut them. Now, we would recognise these all as liver cancer, kidney cancer these days. And what we're doing with that is we're analysing, he's looking at it going, well, these tumours are all the same. Well, we would look at this and say, well, no, they're not the same. They're just cancer of different organs. And there is one of particular interest that he wrote about.
Case of fungus hematoids in the urinary bladder, liver and lungs. IB, a pauper, 68 years of age, had laboured under an affection of the bladder upwards of 5 years. During the last 6 months of his life, he had suffered the most excruciating pain in the region of his kidneys and bladder, attended with almost constant desire to void urine. He felt much pain in the rectum, had a frequent dry cough, accompanied with dyspnea. An examination per rectum proved an enlarged state of the prostate, and slight pressure occasioned great pain. The symptoms daily increased. His health and appetite rapidly declined. On the 16th of March, he voided scarcely anything but blood from the bladder. The quantity, although it flowed by drops, was in the course of 24 hours considerable. This was, in his own words, the most distressing torment. He became feverish, his pulse extremely small and frequent, tongue parched and of dark brown colour, and the sensorium much deranged. In this miserable state, he lived 4 days.
So George wasn't just a surgeon. What we would describe as an early pathologist, because he conducted autopsies on all of these patients.
The first thing on opening the abdomen was a bloody effusion beneath the peritoneum. The fluid proved to be offensive-smelling urine mixed with blood and measuring altogether 3 pints in quantity. My great desire now was to ascertain the course of this unnatural escape of urine. The right kidney was large, very pale but health in structure. Its pelvis had been dilated to a considerable extent. The left kidney was natural, but its pelvis and ureter were greatly distended. After minutely examining the tumour, it was discovered to derive its origin from the prostate gland, chiefly from the middle or third lobe. The fungus or tumour extended laterally and had completely plugged up both ureters, on the right side half an inch beyond where it penetrates the muscular coat of the bladder. The prostatic urethra was nearly closed with the same growth, the remaining part of the tube being quite healthy. In the liver, there were several tubera. There were also several of those tubera in the lungs.
And this is why I wanted to present this case. This is one of the premier minds 200 years ago. And he even classified this as a tumour from the bladder, even though you described it as he recognised it was coming from the prostate. And so this is his understanding and drawing through his conclusions. Even anatomy today from high school, you would be able to recognise what this is. And this is how far we've come as a community, just in our medical information. You can see our understanding of pathology is that cancer is uncontrolled proliferation. The growth that he talks about is a growth from the prostate blocking the ureters on the kidney. So that's why he got so distended. The kidneys would have gone into renal failure from the obstruction. Urine was actually found in the peritoneum, so there was perforation, and that in itself would be fatal.
Because it has to get out somehow.
That's right. And what we also know these days is most of the cancers from the prostate originate in the posterior and lateral regions of the prostate. And so that's why a digital rectal exam, as we're talking about, tends to be a little bit more where the cancer grows, but it's not a sensitive test, as we'll discuss a little bit later.
Well, as I can attest to.
Yeah. And this was the thing, when we're looking at it, he talks about the urethra being involved. That's often a late sign of advanced cancer in the prostate. And he talks about hematuria, and we're involving bleeding that's going into the bladder. Also, the liver and lungs, we're talking about metastatic spread. So whilst this seems that we're just conversing and you understand completely what's actually happening, That is revolutionary 200 years ago.
Right.
And what we would describe this is a 68-year-old male with stage 4 prostate cancer. So when we turn to prostate cancer, even with modern medicine, it is still a challenge. And the reason is because a lifetime risk of prostate cancer is 1 in 6 men. And that's a lot.
That is a very high number.
But the prostate risk of cancer, or the prostate being the cause of death, is about 4% of men. And so we have a lot more people with prostate cancer than people who die from prostate cancer. So most men in the older age brackets will die with prostate cancer than from prostate cancer. And so the challenge here from medicine is we do not have a good means to be able to identify who's got a really aggressive form of cancer that needs to be treated, otherwise they may die from it, to people who have an indolent form that it probably won't cause any issues. And when we look at that, as people get older, 50% of men over the age of 75 to 80 years will actually have evidence of prostate cancer, little foci, if autopsies are done. And so the challenge is, who do we intervene on? Who do we not? And this was where PSA comes in, digital rectal exams come in, because digital rectal exams are actually not a really good test for prostate cancer because it's not very sensitive. It's about 50%. It's not very specific, so it doesn't rule them out. It's about 60%. And so people who need to advance to biopsy, about 2% of them will have complications, and that can be anything from an infection, pain, bleeding, urinary obstruction. And so that's a significant amount of people you'll potentially be investigating who may not need further investigation, or they may.
Hence the murkiness of the situation.
That's right. And so what do we know? We know that if you have a family history, so this is about 10% of prostate cancer. If you have a family history, you have a twofold increase of having prostate cancer. If you have 2 relatives less than 65 who have prostate cancer, you have a 4-fold increase. And that's where this brings us to PSA. So as I said, this is a normal enzyme, and it's not specific for prostate cancer. So any disease process in the prostate can make it elevated. And so when we're looking at that, benign prostatic hyperplasia, so that's just normal swelling of the prostate gland. It affects 50% of men over the age of 50 and 60, and 90% of men over the age of 80, and increases with age, as you can see. But it's not a risk factor for prostate cancer, but it will rise
the PSA readings.
Exactly. Yeah. And so if you have inflammation of the prostate, prostatitis, that will increase and can significantly increase. But once prostatitis is resolved, PSA should go back to baseline. Sex can increase it, cycling can increase it, and digital rectal exam can increase it. Now, the people you get most worried about are people who are on the cusp of our sort of reference range for PSA. So if these people have, let's say, prostate stimulation for whatever reason, it might click them over into the range of, okay, it's not worrying about, it might be a bit elevated. And so this adds to that challenge. To add to this complexity,
there's more.
The guidelines are not clear depending on which urological society you're looking at. Some will say digital rectal exam is not a useful screening test, don't do it. And some will say digital rectal exam with PSA is useful. It is just a challenge. And this is the problem, because with the digital rectal exam, the majority of screen-detected cancers are not palpable.
Oh, really?
So, yeah, and so this is the challenge. This is where we find ourselves. And the reason why this discussion is important is because we've got new guidelines coming out, particularly in Australia, about Medicare, about what is important for people with testing, what are the results that need further, and we're also bringing into it now that we have additional imaging, who is eligible for prostate MRI, for bulk billing purposes being billed by Medicare. So we have an expert coming up who's going to help us try and sort out some of the murkiness of this area.
I'll just readjust the pillow on my seat. Professor Ken Sikaris is a chemical pathologist and Director of Chemical Pathology at Melbourne Pathology. Professor Sikaris is a NATA-accredited laboratory assessor, founding fellow of the RCPA Faculty of Science, and a principal examiner in pathology informatics. He's a fellow of the Department of Pathology at the University of Melbourne. And of course, Professor Ken Sikaris is a regular guest here on This Medical Life podcast, and we'd like to welcome Ken today to continue our discussion of prostate specific antigen or PSA testing. Welcome back, Ken.
Thanks, Steve. Great to be here again.
Yes. Well, look, Ken, so far we've discussed some of the challenges of using PSAs in regards to screening for prostate cancer, but the big question is, when is PSA testing recommended or appropriate?
I mean, there's no national guideline for screening. Well, there's no national program for screening, but there are some Australian guidelines, and they were derived from a NHMRC supervised review of PSA testing in 2016, and they a lot of that was based on a big European study which had shown that prostate cancer screening can save lives. So that was really the strongest evidence that prostate screening might work. In that study, they sort of were screening men from the age of 55 or 60, and they showed a mortality benefit in the men that was screened. It was a small mortality benefit, only 21% reduction in deaths. Nevertheless, it was a benefit, and with time, that's proved to be a little bit more than 21%. So you might say, according to the evidence, you should start at age 55. Mm-hmm. But the other thing in that study, which was important, was that of all of the men that died, most of those with cancer, died of prostate cancer, most of those were detected in the first screening round. So in a way, when they were 55, they already had the cancer. And so people knew that 55 was too late for a significant proportion of men who would die of prostate cancer. And so most of the guidelines sort of push that 55 down to 50. Now, there are some other men who are really at high risk, two to three times the average risk of cancer. That's with family history. And for them, they often die at an earlier age than those men without the family history. So therefore, the guidelines, even though that wasn't part of the study, said that, well, to catch those men, we'd have to start even earlier, either 5 years before 50 or 10 years before 50. And in the guidelines, they sort of say, well, if you've got a bit of a family history, start at age 45. If you've got a strong family history, start at age 40. But the long-winded answer to your question is that you start at age 50 for most men. And if you've got a strong family history, you start at age 40.
So looking at the evidence, they talk about with PSA categories, something such as less than 4 micrograms per litre, between 4 and 10, and greater than 10. Now, are these still useful categories for people to be put into?
Not accurately. In concept, they are. So less than 4 is sort of men who are considered to have a normal-ish PSA. So it's a PSA that's indistinguishable from men that don't have prostate or wouldn't have prostate cancer. 4 to 10 is sort of the grey zone, and over 10 is like a alarm zone. Once you're over 10, it's odds on you've got a cancer. So sort of low risk, medium risk, high risk. But again, in that European study, they found that the best cutoff was not 4 but 3. So three was used in the study, and 3 was what was worked for reducing mortality. So they decided the cutoff would be 3. The other thing about PSA is that naturally the prostate gland grows with age, particularly between the ages of 40 and 60. And so a normal PSA would be less than 2 in a 40-year-old and would be less than let's say 3 in a 50-year-old and less than 4 in a 60-year-old. And so whilst our focus was on 60-year-olds in the past and the cutoff would have been 4, our focus is now on 50-year-olds, and therefore the cutoff is around 3 for most men. And for those men with family histories where they're, the normal levels are less than 2 at age 40, the cutoff is 2. So for the majority of men without a family history, the cutoff to have in mind is 3. So above 3 is sort of unusual for a man, and therefore they should be considered at increased risk. If you're below 3 at age 50 and on, then you're considered to have a normal PSA, and therefore you don't need to have urgent follow-up.
Now, there is a test that is called free PSA. And how useful is this test?
It's surprisingly useful. So in the early days of PSA testing, and I'm old and grey enough to remember those days, when we were measuring PSA, the results were all over the place. And it soon became obvious that PSA in the blood and in semen and prostate has multiple forms. And so there's free form and a protein-bound form. And so the early assays were, which one did they measure? Free or bound, or predominantly free or predominantly bound? So the results are very different. And so we got on top of that and decided, well, we wanted to have assays that responded equally to the free and the bound so that they're consistently measuring the total PSA level in all men. They're called equimolar assays. But then people started wondering, well, what's the difference between this free and the bound? Has that got a relationship with cancer? Is one of the forms more common in cancer? And surprisingly, the bound form is what's more common in cancer. So normally 70% of the PSA is bound to proteins in the blood. But if it's like 90% bound, then you've got a high risk. Now, we've switched that around. So if it's less than 10% free, you're odds on to have cancer. It's a funny sort of explanation for why that's so, but the free form has got a very short half-life. It's sort of after ejaculation, for example, you'd get a shower of predominantly free in the blood, but it would disappear very quickly. And generally, day-to-day perturbations of the gland will lead to these showers of free, so you get predominantly free in the blood. But if you haven't got that normal variation as the cause of your high PSA, and it's constantly high, that's got nothing to do with these showers of natural free. That's got to do with a sort of insidious, slowly rising PSA, which is predominantly bound. That's sort of the more stable half-life. So high levels of bound PSA sort of tell you that the PSA is high, probably constantly high, probably rising.
I'm constantly amazed at the academic acrobatics that happens in this field of medicine. It's almost like trying to see things through a mirror in reverse and put them together. It's absolutely wonderful.
Well, it's whoever gets in first. They set the standard, and all the rest have to look at the mirror image.
So we've got the free PSA. So I've seen the category between 10 and 25 as higher risk. Is that right?
Okay. That's right. So I said before that over 90% bound or less than 10% free is high risk. But a bit like a total PSA, there's sort of a grey zone of risk, a low risk zone and a high risk zone. So less than 10% free is high risk. 10 to 25% is a medium risk. And over 25% means that there's very little risk. Because over 25% is like those showers of PSA, that sort of benign form of PSA elevations. Now, the average level, if the median of the population, is 25%. So all it's really saying is that if your free PSA is below 25%, your free PSA is below the average for the population. Therefore, your risk of cancer is above the average for the population. But it doesn't mean if you wanted to biopsy everyone with a free PSA of less than 25%, you'd be biopsying half the population. So it's not meant to be a high-risk prediction. It's meant to be you're above average risk, we need to keep a close eye on you.
Right, okay. So then With doctors looking at it, would you say they order PSA/free PSA? Or do we automatically give results of that? Or are we coming to that with the new guidelines?
We are coming to that with the new guidelines, but it varies from state to state. The Medicare statistics show that almost depending on the medical school you went to, you either trained about free PSA or you weren't. And so you'll find that some states have half the GPs requesting free PSA when they should, and others would have like 20% of GPs requesting it. So it's the awareness about the usefulness of PSA is not as good as it should be. But I think most doctors have heard of it, but they're not quite sure exactly how to use it. And that's where the guidelines come in. And that's where the new Medicare guidelines have really made it crystal clear about its appropriate use.
Okay, we'll be coming to guidelines in the next little segment, but there's a few other tests I want to ask you while we've got you here. Is PSA velocity or doubling time useful?
Well, I was on the 2016 guideline committee, and we concluded that there was no evidence for PSA velocity or doubling time in the screening of prostate cancer. Now, that no evidence for doesn't mean evidence against. And interestingly, that's a question that we're asking again because there might be evidence now. It's been 8 years really since the end of the RCP study. So there's a review of the literature to see whether the velocity and doubling time do add to the story. And in a way, of course it does. The quicker the PSA is rising, then obviously the more aggressive the cancer must be. I do prefer doubling time myself, as most urologists do, because doubling time is a truer reflection of tumour growth. One cell becomes two become four.
Now, the doubling time is the rate rise of PSA over a year?
Over a year.
Okay.
And generally, if it's rising, well, the doubling time is how many years does it take to double. Right. That's the strict definition. So now I said before that men naturally grow their gland between the age of 40 and 60. And so the maximum doubling time for BPH, benign hypertrophy, is about 5 years. So men in that aggressive phase of benign hypertrophy have their PSA doubling every 5 years. So that's not a concern. If the PSA is doubling faster than every 3 years, well, then you've got a risk of something which is probably not BPH. And if it's doubling every 1 year, well, then good luck, because that's a very aggressive PSA rise. It's more likely you've got a high-grade Gleason if you've got a PSA doubling time of a year. I have to say as well with the doubling time, because there's a difference in the doubling time post-surgery, post-radical, and the doubling time when you've got an intact gland. The numbers that I've been talking about are the doubling time with an intact gland, but in post-radical surgery where you might have a nest of remaining cells, we talk about doubling times of not 1 year being aggressive, but 3 months being aggressive. Okay. So, but that's a different assessment, so it can be confusing in the literature.
Sorry, there's another test, PSA density. Is that in the same category, or is that completely different?
No, it's different. So that's a moment in time assessment. So here's your PSA. Now, we've said BPH will cause a rise in PSA. Well, why don't we compare the size of the gland with your PSA level? If your PSA level is appropriate to the size of your gland, then you probably don't have a cancer. Whereas if your PSA is elevated and you've got a small gland, well, then something's strange going on. It's probably not benign elevation. So that's the concept of it. There are figures for it where you can measure the volume of the prostate by ultrasound or MRI, and then and I don't know what the cutoffs are exactly, but urologists can do that. Once they've got the volume of the gland and the PSA, they can look at the ratio and say, this is a high ratio. It's really only a specialist assessment, and it is a useful assessment, but it's not useful in the screening sense because you wouldn't have had the ultrasound or the MRI unless you've had high risk anyway.
There is a test called the Prostate Health Index. I'm not sure, is this abbreviated to a PHI or PHI test?
PHI, I'm Greek, so phi.
Oh, okay, there we go, phi, yeah.
So it's meant to be very sort of ancient Greek, with the, but it is slightly better the total PSA has a prediction efficiency, let's say, of 65%. The free PSA is like 75%, and the FI might be about 80%. So it is slightly better, but it costs a fair bit. So the difference between it, the FI is really just the free percentage of PSA plus one other measure. Now, even though I've said the lower your free PSA is, the higher your risk. There is a form of PSA that, even if it's in that small fraction, is very aggressive, and it's called a pro form of PSA. It's a primitive form of PSA that hasn't had its cleavage done yet, and so on. So pro PSA is an immature PSA and more likely to be present in cancer. So they measure the pro PSA and the free to total and create this magic number, and it's the FI test. Again, there was no evidence in the European study that FI was more useful. There is some not controlled evidence that it's more predictive. Some urologists like doing it because they like to see whether there's pro PSA present and might be particularly useful post-radical. But it hasn't really found a place yet. There have been many more studies. So again, the new review of the screening guidelines, which only started this year, so it's going to take 2 or 3 years to finish, we'll be looking at FI to see whether it should also be included. But at this stage, there's no evidence for it. There's just a conceptual support for it.
Do you think in your mind's eye, do you see this will be something where we're going, where Medicare will cover the FI test?
If it's proven to be useful, yes, they will, because the way that the new schedule works is that the free to total is the gatekeeper test for the MRI, and the MRI is quite expensive. So if you can introduce a relatively cheap test, $10 or $20, to improve the efficiency of the power of the MRI to find the right men, then it will come in. But that needs a lot of information. So to be honest, I don't expect that evidence is through yet. So I don't really expect that the schedule will be changing in the next 3 to 5 years.
Ken, I sense Travis has run out of tests to ask you about, so I'm going to flip the question differently. Are there any other useful tests that you're aware of now or can see coming in the future for the early detection of prostate cancer?
Probably not, Steve. I'm so old. I've heard of hundreds of new tests that are supposed to improve things, and none of them have. A bit of a trick in this game of new markers is that they come in and say, we found a test which is better than PSA. Okay, that sounds interesting. The question should be, have you found a test better than free to total PSA? Because that's the better test. And most of those new markers do not compare themselves with the current gold standard of the free to total. And if they did, a bit like the FI, which is only slightly better than the free to total, they don't really add much. They add as much noise as signal. So there's sort of swings and roundabouts with any new test. There's no real gain. So I'm sorry, because people would love to have a better test. But the other way around, it's remarkable that a test found in the mid-80s has stood the test of time so long.
Well, thank you for giving us that rundown from the alpha to the omega of the current test. Let's pause for a quick breath and come back to continue the conversation. Professor Ken Sikaris is back with us in this episode on PSA. Ken, can you tell us about the new Medicare guidelines that at the time of recording, they're set for November 2023 in relation to PSA testing?
Yes, so I mentioned the 2016 guidelines, and I mean, everyone knows from the college to the government, it's been an enormous frustration for me being involved in the development of the guidelines that it's taken 8 years to translate them into the Medicare rules for PSA testing. That was because there was an MBS review in the middle of it, and people were looking at pathology requesting in general and whether we need clinical decision support to help doctors. And so there was a lot of interruptions in the process, but it's been overdue, but at last it's there. So it's totally based. The Medicare items were designed 7 or 8 years ago based on those 2016 guidelines. Interestingly enough, in the last 8 years, there's been another Medicare change, which is Medicare has allowed MRI as part of the testing procedure. And the 2016 guidelines did not have MRI as part of the testing procedure. And so the MRI guidelines came in and leveraged the 2016 guidelines before the PSA testing came. So it was all a bit, anyway, you can probably sense my frustration.
Yes.
But, there are some basic issues there. The old item for PSA testing, when you don't have prostate disease, i.e. screening, was to have a PSA test every year. The new guideline says that you're entitled to a new test every 2 years. Now, they've allowed a little bit of grace because some men turn up, 1 year and 364 days before the 2 years, and Medicare says, no, you're not entitled. So they've made it 23 months, so they can turn up a week before the 2 years was due. And conceptually, this was to do with the screening period in the European study. What they showed was 2-year testing was sufficient to prevent or to pick up cancer. And there were very few interval cancers. And also, when you think of it, colorectal screening is not every year, cervical's not every year, breast not every year. So why would prostate cancer, which is not as aggressive as many of those, be every year? So it should be at least every 2 years is where the guidelines settled. So that's the first thing. The first item says you're entitled to a PSA once every 2 years. If the PSA is abnormal, now according to the guidelines, abnormal was above 3. According to the research study, it was above 3. So if it's above 3, then you should retest because there may be a transient elevation, and you should retest with a free to total ratio. And if the PSA remains above 3 and the free to total ratio is in that increased risk category of less than 25%, then you're entitled to an MRI. And that's really added a lot of specificity to the testing because of the free to total. And the repeat as well adds a lot of specificity to testing. I'm sad to say, over my time, I've seen lots of men sort of sent to urologists after a single PSA level. Most urologists would repeat it before doing anything, but 30% of PSAs which are elevated will normalise on the repeat test. So they're true, they're really high risk false positives and a lot of anxiety and stress. Just in relation to that, the repeat test is meant to be done about 4 weeks after the initial one to confirm that it's elevated. People say, well, I've mentioned ejaculation can cause a rise in PSA. So shouldn't you, abstain from ejaculation for at least a couple of days before the PSA test? Well, yes, if it's a repeat test, definitely abstain. But the initial test doesn't matter if it's high because you forgot to abstain because we're going to repeat it when you've abstained. So it's not as important. Ideally, yes, all PSAs should be done after a couple of days of abstinence, but it's very important for the repeat test.
Just with regards to the repeat test, so done about a month after the first part, there is some, I've seen some classifications. So the classification is greater than 2. This is the actual result. So if the result is greater than 2 micrograms per litre, but less than 5.5 if they have a family history.
Okay, yeah. The other level of it is that if your PSA is above 5.5, I don't care what your free to total is. You're sort of at a high risk. So really 5.5 is a new level of risk. And most patients whose PSA is above 5.5 will have a free to total below 25%. So even though you can test for it, it's sort of, you're shifted into that very high risk group. Now, the less than 2, you mentioned that less than 2, Travis, rather than less than 3. Less than 3 is the cutoff for most men. And if they've got a family history, the cutoff is less than 2. No, so that's the men who are being tested in the 40s should have a family history. You shouldn't be tested in your 40s if you don't have a family history. The risk is so low. But let's say you've decided to start testing and you're 60 and you've got a family history because you haven't tested earlier. Well, the cutoff is 2. So we know that you're at high risk. So less than 2 is the cutoff for men with family history. Less than 3 is the cutoff for other men. And in that zone of 2 to 5.5 or 3 to 5.5, you do the free to total to distinguish who's at high risk. But above 5.5, you shouldn't really be reassuring a man, because above 5.5, the risks are really high. They should be referred and assessed by a urologist.
These patients would have a repeat test. Now, I haven't seen any reference to free PSA here, though, with these categories. Is that me missing it?
No, they should be having a free to total test.
Yeah. Okay, so that will be included in the assessment.
Yeah, now, we mentioned before, will the lab do the test? According to Medicare, unless you tell us what you're doing, labs don't know whether this is the first or the second test.
Right.
Because you might have gone to a different lab, which is, for PSA, that's actually not a good thing to do. You should stick to the same lab because there are slight differences in the methods. Yeah, so potentially if a lab sees you a month after the last PSA, they might sort of ask the doctor, well, is this a confirmatory test? Did you want a free to total? But according to Medicare, the doctor's supposed to ask for it. It's not a pathologist deemable test.
Right.
So you're supposed to ask for it. Some practices have been doing it automatically, whether they bill Medicare or not, I'm not sure. But you should be asking for that free to total.
Okay. So if a doctor is actually sitting in front of a patient, the first test is just PSA screening cancer, and okay.
Yeah, I mean, because it's not a national screening program, it hasn't been separated out like the fecal occult blood and breast and so on. We sort of avoid the term screening because that implies there's a national screening program. So, but it is screening. It's called PSA testing. So, but it's so if a man doesn't have a history of prostate disease and they're trying to assess their risk for prostate cancer, then you'd order just a PSA.
Okay.
And then, I mean, you won't get a rebate for the PSA unless the PSA's the free to total. You won't get a rebate for it unless the PSA is above 3 for most men or above 2 for other men. So, and labs shouldn't really be doing it when the PSA is normal, because if the PSA is low, it's reassuring. The free to total doesn't suddenly make it, high risk. It's low risk.
Okay. With these changes, so this is changes from the 2016 area, is that right?
Yes.
Okay.
Yeah.
So this has been coming for a long time.
It's been coming for a long time. I mean, there were sort of a shadow of it in the old guidelines. We said if your PSA was above the median was about 1 or 1.5, then you should consider repeating it with the free to total. But according to the evidence, it's useful when the PSA is not above average, but above 3.
So I'm just trying to get in my mind what the doctor requests. So in a pretty much, if someone has come and they've had the discussion, they wanted to have some PSA screening test.
Yeah.
The initial test is a PSA, and if that's elevated, the test, the follow-up test a month later is PSA/free PSA.
That's right.
With and stating second test.
Yeah, you can say follow-up PSA. I mean, the lab will know. If you went back to the same lab, they will be able to recognise you had a test a month ago, and so the repeat PSA and free to total must be a follow-up PSA, and they'll have the results to show that it was above 3 last time, and therefore bill Medicare for the repeat. Another reason why it's important to go back to the same lab. And
then also the family history will be important to say, because that will be important for the results.
Well, for the interpretation of the results, it's important, because is the cutoff 3 or is the cutoff at 2? It depends on the family history. So now most laboratory systems, won't be able to read the various ways that doctors might write family history, because, doctors might write on the clinical notes, no family history. And believe it or not, I don't read every request form that comes to our lab because there's 15,000 a day. So we rely on the computer reading it. And the computer relies on a clerical person reading the doctor's handwriting, so it becomes a bit fuzzy.
Mm.
So it's very difficult for the laboratories to put a cutoff of less than 2 when they know it's a family history, or less than 3 when they don't. So what they'll probably do is use the cutoff of less than 3 if they know this is a screening test, and then there'll be a note to say if there's a family history, the cutoff should be less than 2.
Mhm. Okay. So if we have 2 tests that are repeated and still elevated in that area, is this where a urology referral will go in, or is that where they are eligible for an MRI prostate assessment?
Both. Only a urologist can order the MRI
Right.
in that circumstance. The urologist can also order the MRI if he independent of the PSA levels, if he considers the patient at high risk. That might be on the urologist's digital rectal examination.
Okay. All right. So then looking at this, we will actually just provide the information, and okay, that goes from there. I'm just trying to get clarification as to what. So I think that's clear.
So you're right. That's the biggest issue with the new guideline. We want to know something about the patient. Remembering, and PSA is no different to every other test we receive in the lab, 40% of our request forms have nothing on them. So we don't know whether a patient who's having a PSA, it's their first PSA, it's their follow-up PSA, they've got prostate cancer, they're being monitored. We don't know anything. And so we won't know how to report properly, because there's a difference between reporting, a patient with prostatitis, known prostatitis, and a patient who's been screened with disease.
Mm.
We don't want to be putting on a man who's got prostatitis and having a PSA to see whether it's settled a comment saying your PSA is above 3, you better have a free repeat and an MRI. So it's a different clinical question. So so if possible, every doctor should put a note on any PSA request, and not only for the sake of laboratory testing and reporting, but also for the sake of the patient, because they might get billed for a test which they deserved.
So now these guidelines click in on the 1st of November. Is there going to be any change to reporting on this, or this is just something for GPs to know about?
No, there'll be a big change in reporting, because at the moment we don't use the less than 3 cutoff in our reporting. So if a man's having their first PSA, the lab should be reporting a less than 3 as the reference interval, as a cutoff, and flagging everything above 3. At the moment, we're using age-related cutoffs: 2 at 40, 3 at 50, 4 at, and so on. So those age-related cutoffs, which is the reference interval for PSA, is not relevant for PSA screening. There's a clinical decision point for screening, which is 3. Whereas the age-related cutoffs might still be relevant when you're trying to decide whether this man's got prostatitis or not. It's a different question. Are they normal or abnormal? Well, for a 70-year-old man, a PSA of 6 is normal. But if in a 70-year-old man the question isn't, do they have prostatitis? It's, might they have prostate cancer? 6 means, yes, they might have prostate cancer.
Ken, I'll just say for people listening that Travis looks satisfied now. You've helped him put his finger on it, so to speak.
Good.
Is there any final advice or thoughts you have for GPs about PSA testing?
Yeah, look, like I said, it's been a long time since the 2016 guidelines. And there's been 3 radical changes. The MRI means that only men with suspicious MRI lesions should have a biopsy. So the confidence we have before biopsy is enormous. The other thing is, in 2016, when the guidelines came out, most biopsies were transrectal biopsies, which had a risk of infection. Now they're virtually all perineal biopsy, which carry no risk of infection. That's been a massive change in the harms that might come from PSA testing. Yeah, and then there's also, which Travis will know about, the shift in classification of the biopsy. So rather than saying you've got a cancer which is 6 out of 10, which sounds to a layperson quite aggressive, it's actually quite safe, one that's worth monitoring. And so that shift in the classification of tumours have really progressed in the last 7 years. So if the guidelines were appropriate in that relatively high-risk environment of 2016, they're highly appropriate for today's environment where the risks of overdiagnosis and harms of testing are vastly reduced.
Well, there you go. Professor Ken Sikaris, thank you so much for joining us yet again. And I'll talk to Travis after this. I'm suggesting we have the Sikaris protocol, Travis, and we have 2 days of abstinence before recording any episode of this podcast. Ken, thank you again.
Thanks, man. Bye.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts via Twitter. Dr. Travis Brown is at Dr. Travis Brown. That's DR for doctor. And Steve Davis is at Steve Davis. Editing and production is by Tim Whiffen. Design is by Tom Buzenjut. This has been a PathNotes Proprietary Limited production.
Hi, Jeremy Cordeaux in the Court of Public Opinion. I'm just on air here to let you know that we'll be live streaming the Court of Public Opinion every Friday between 9 o'clock and 12 on jeremycordeaux.com. Please join us. We'd love to have you.